Hello, my name is James Pantling Skeet, and I'm a community care specialist at Leicester Aldridge Solicitors. I'm here today with the Brain Injury Group to provide an update with regards to the hospital discharge process and NHS and local authority funding following the Coronavirus Act 2020 and the coronavirus regulations which were passed earlier this year. The reason for today's webinar is because there have been some changes that have been published over the last 2 weeks, which take effect from the 1st of September 2020. And so we thought it would be a useful point to revisit the changes that we covered in an earlier webinar that's available on the Brain Injury Group's website to see what changes we can expect from the 1st of September. So, the points that I'm going to cover in this afternoon's webinar are as follows. Firstly, I'm going to have a look again at the Coronavirus Act 2020 and the associated coronavirus regulations, and just give you a quick recap on the implications that the new legislation has on NHS and local authority funded care. I'm then going to give an explanation of the changes to the hospital discharge process and the NHS continuing healthcare assessment process, and these changes are effective from the 1st of September 2020. And in preparation for the reintroduction of NHS continuing healthcare eligibility assessments, appeals and annual reviews, I'm also going to give a quick overview of what NHS continuing healthcare means and what you can expect from the assessment process for anyone who's not familiar with what to expect as a result of these processes, where up until now, since the coronavirus that was passed, NHS continuing healthcare eligibility assessments have been on hold. So I just thought before I go into the detail that it would be useful to signpost to everyone the key guidance documents that you may wish to familiarise yourself with. I've bullet pointed them on the slides there, and they've got hyperlinks to each of the resources. If you're unable to access the links from the recording directly, the Brain Injury Group will make the slides from this presentation available on the Brain Injury Group's website, so that you should be able to access the links from the PowerPoint slides instead. But the key ones that you really should be aware of at this stage are the Care Act easements guidance. That hasn't actually been updated since the 20th of May, and I will give a quick update as to how we have seen, or what we've seen rather, in terms of the practical implications of the changes to social care since the easements guidance was published. More recently, only on the 26th of August, we've had the publication of an overview of adult social care guidance on coronavirus. And this is actually a really useful document because it's pulling together all sorts of different COVID-related guidance documents that are available on the .gov.uk website. But obviously, as time has gone on through the pandemic, we have seen an increasing number of guidance documents published, and it's actually quite confusing, or can be quite confusing, to navigate where all of these guidance documents are located on the .gov.uk website. And so rather helpfully, this overview document that's been published actually has summaries of some of the key guidance documents and links to it all in one handy place. So if you're ever unsure of where to find things, I would suggest that that may be a good starting point. The key documents that relate to the bulk of today's presentation are the reintroduction of NHS continuing healthcare guidance documents that was only published on the 21st of August, the updated hospital discharge service policy and operating model that was published on the 21st of August to replace the previous hospital discharge service requirements published on the 19th of March. And then finally, the national framework for NHS continuing healthcare and NHS funded nursing care. And this was last revised in October 2018. Now, the reason that the national framework is worth familiarising yourself with is because as part of the changes that are effective from the 1st of September, NHS continuing healthcare eligibility assessments, annual reviews and appeals will be restarted. And so it's worth familiarising yourself with this document because the national framework provides all the rules and processes in relation to NHS continuing healthcare assessment processes. So it's useful to be familiar with the terms and the provisions of the document. So, the Coronavirus Act 2020, well, the first question that you're probably all wondering is what's actually changed? And in case you haven't listened to the webinars that we provided in April of this year, I thought I'd give a quick reminder of the key changes as a result of this new legislation. And they are as follows. A simplified hospital discharge process, whereby a simplified procedure, meaning we have a discharge to assess model where the focus is on discharging patients the same day that they are deemed medically fit for discharge from a hospital setting. We've had modifications to the NHS continuing healthcare and NHS funded nursing care processes. So up until the 31st of August 2020, NHS continuing healthcare assessments, annual reviews and appeals have been permitted to be put on hold by CCGs in order to allow the NHS to prioritise and redeploy staff to other parts of the NHS in order to meet the demands placed on the NHS as a result of the coronavirus pandemic. It's probably worth pointing out that whilst the Coronavirus Act effectively gave CCGs the ability to put these processes on hold, it didn't actually stop them from undertaking NHS continuing healthcare eligibility assessments, completing annual reviews, or from processing appeals. And I have actually, in fact, seen with a number of clients that we work with at Leicester Aldridge that CCGs, particularly in the last 6 weeks or so, have started to work through the backlog of eligibility assessments and appeals that had previously been put on hold due to the Coronavirus Act 2020 and the pressures on the NHS in meeting the acute hospital needs and other needs of the NHS as a result of COVID. Another key implication of the Coronavirus Act 2020 related to social care funding. And there was quite a lot of controversy at the time that the legislation was passed because it did make some rather far-reaching changes to the Care Act 2014. And for those of you that don't know, the Care Act 2014 is the key piece of legislation governing adult social care provision. The Coronavirus Act 2020 introduced this concept of Care Act easements, providing a process that local authorities could follow in order to instigate the ability to operate or initiate the Care Act easements and effectively relax some of the statutory duties in the Care Act 2014. And then we also had some temporary changes to special educational needs provision, and in particular an alteration to the absolute duty in section 42 of the Children and Families Act 2014 to provide special educational needs provision in accordance with Section F of a Child or Young Person's Education, Health and Social Care Plan. And that absolute duty was temporarily changed to one of reasonable endeavours, along with some changes to key timescales in the EHCP assessment process. If you do want to familiarise yourself with the changes that I'm going to be obviously now revisiting in this webinar and what the case was before in more detail, there is a link on the slide there to the previous webinars that we provided in April, but obviously that content now is to be updated with the content of this webinar, so I would say that you should follow this one as the current position in terms of the most up-to-date information that's available. The previous webinars are for reference only. So, in terms of updates, the focus of today's webinar is going to be on the updates to the hospital discharge process and to NHS continuing healthcare, which are effective from the 1st of September 2020. Interestingly, with the local authority funded social care changes, whilst, as I said a short while ago, there was a lot of controversy and concern expressed about the possibly far-reaching consequences of the changes to the Care Act 2014 as a result of the Coronavirus Act 2020 and the introduction of the Care Act easements process. Actually, there was only a handful of local authorities earlier in the peak of the pandemic who followed the required steps to instigate and operate under easement. And as it stands, as of the 28th of August 2020, there are currently no local authorities who have registered or reported to be operating under easement. So the net effect of this is that as it stands, all the local authorities in the country in terms of adult social care duties should be operating as per the usual processes provided for within the Care Act 2014, and none of them can seek to rely on the Care Act easements unless they have followed the specified steps to actually act under those provisions. So there shouldn't be any changes to adult social care provision at the moment, albeit things like assessments and visits and check-ins, annual reviews, things like that are probably largely still being done over the telephone or through video conferencing in order to minimise contact between individuals and comply with social distancing. And because of the fact that there are no local authorities currently registered or reported to be operating under easement, I'm not going to go into any more detail about the changes to adult social care in this webinar. Again, if you wish to find out a bit more about what a local authority can do if they have taken the specified steps to operate under the easement process, I'll refer you to our previous webinar, albeit at this point in time, as it stands of the 28th of August, it isn't relevant because there are no local authorities currently operating under easement. Obviously, this is subject to change. And if you go on the CQC's website, you can see where, as and when a local authority has reported that they are operating under the easements. And then, just as I mentioned already, special educational needs provision, all you really need to know at this point is that the changes that were in place previously to the absolute duties have now been reinstated. The modification notices issued by the Secretary of State in May, June and July are no longer effective because the Secretary of State did not issue a further modification notice in August. And also the relaxation to key timescales, which is due to end on the 25th of September, will actually come to an end. It has been confirmed in the updated guidance document on the 26th of August that there is no intention to extend those relaxations to key timescales beyond the 25th of September, which will be a welcome relief to a number of families obviously dealing with the special educational needs system and the legal framework. And finally, there are actually no changes as a result of the Coronavirus Act 2020 to children's health and social care statutory duties. And indeed, this has been made explicitly clear in the updated children's social care guidance. So that was just a quick overview of where we are in terms of the changes the Coronavirus Act 2020 and associated regulations have made to the key aspects of health and social care and also special educational needs provision. I'm going to move on now to the updates that we need to work our way through in relation to the hospital discharge process and NHS funded care. So there was a recent letter issued by NHS England, and it set out 5 principal priorities for the next phase of the NHS's coronavirus response. And the intention stated in this letter is to accelerate the return of non-COVID health services, making full use of the capacity available in the window of opportunity between now and winter. So what does this mean? Well, effectively, what the NHS England wants to do is start to try and get things back to normal between the window of opportunity we have now and as we get into the winter months where it is feared that perhaps there may be a second wave. Crucially, for patients in receipt of care funded through the temporary COVID-19 NHS funding, and that was the funding that was put in place when eligibility assessments for NHS continuing healthcare were put on hold, or CCGs were given the ability to put them on hold during the earlier phase of the pandemic, the hospital discharge process, will be updated from the 1st of September. So clinical commissioning groups are therefore have been instructed from the 1st of September to resume NHS continuing healthcare eligibility assessments, the 3-month initial checks once eligibility has been awarded, and the annual reviews that should take place every 12 months, as well as processing appeals. As I've said earlier, while CCGs were afforded the ability not to conduct these assessments and appeals as a result of the Coronavirus Act 2020 previously, there was nothing actually stopping them doing so. They weren't prohibited from processing eligibility assessments and appeals if they had the resources to do so. And from what I have seen and the clients that we support at Leicester Aldridge, CCGs have actually been trying to process annual reviews and appeals in the last 6 weeks or so using video technology. So this is obviously welcome news for those people who have been waiting in the backlog essentially. And interestingly, there is an estimated backlog, according to a recent article. This isn't stated in NHS England's recent letter, but was reported on communitycare.co.uk, of 25,000 assessments that have not been carried out since NHS eligibility, NHS continuing healthcare and NHS funded nursing care processes were suspended on the 19th of March 2020. Again, as I've said, whilst CCGs were afforded the ability not to do them, there was nothing stopping them from doing so. It's interesting actually to point out that whilst this recent article reported on communitycare.co.uk estimates there's a backlog of 25,000 assessments, at the time of the original hospital discharge service requirements publication in March, the estimates in there was that it was going to create a backlog in excess of 5,000. Well, obviously that's 25,000 is a significantly higher number than 5,000, albeit that a number of commentators at the time felt that the estimation of 5,000 was probably rather conservative. So obviously with this backlog, I think it's obviously going to be quite clear that it may well take some time for NHS bodies to get through the assessments, and so we may see that key timescales start to slip. So from the 1st of September, what is going to change? Well, NHS England's letter actually quite neatly summarises the key things you need to understand about the revisions to the hospital discharge service requirements, and it states as follows. The government is continuing to provide funding to support timely and appropriate discharge from hospital inpatient care in line with the forthcoming updated hospital discharge service requirements. We have now had that updated hospital discharge service requirements, and so I will explain that in a bit more detail shortly. From the 1st of September 2020, hospitals and community health and social care partners should fully embed the discharge to assess processes. New or extended health and care support will be funded for a period of up to 6 weeks following discharge from hospital, and during this period, in a comprehensive care and health assessment for any ongoing needs, including determining funding eligibility, must now take place. The fund can also be used to provide short-term urgent care support for those who would otherwise have been admitted to hospital. And with regard to NHS continuing healthcare, the letter summarises that from the 1st of September, the government has decided that CCGs must resume NHS continuing healthcare assessments and work with local authorities using the trusted assessor model. Any patients discharged from hospital between the 19th of March and the 31st of August 2020, whose discharge support package has been paid for by the NHS, will need to be assessed and be moved to core NHS social care or self-funding arrangements. So, how does this impact funding care? Well, the answer is once the temporary COVID-19 NHS funding ceases, and that's obviously going to take effect from the 1st of September, patients, families and their representatives are going to need to think very carefully about the funding of care. Unless and until eligibility for NHS continuing healthcare, which is non-means tested, i.e. free, or a jointly funded package of care whereby the local authority and the NHS agree to split the cost of a package in recognition of the fact that an individual may have health and social care needs, a patient is going to be a self-funder unless they satisfy the means testing rules for social care provision. So if the patient is likely to be a self-funder, there's obviously going to be need to be a question of how will the care costs be met, and advisors and representatives and attorneys and deputies may well need to start considering taking financial advice, for example, on what options may be available in the situation where the patient is going to be a self-funder, particularly given how expensive care can be, particularly if the patient is going to need care in a residential or nursing care facility. You also should be aware that the period of funded recovery services, which is what it's called in the updated hospital discharge service guidance, is for a period of up to a maximum of 6 weeks only. Now, there is guidance as to what happens once the 6 weeks has passed, but the guidance is quite explicit that it is envisaged that patients should not really be funded beyond the 6-week period, and it should be rare for a patient to still be requiring an assessment after that 6-week period has ceased. So there is the possibility, therefore, that a patient who is discharged from hospital now, well, from the 1st of September rather, could be funded by the NHS for a period of up to 6 weeks until the necessary assessments have been taken place. But that doesn't mean it's guaranteed that the patient will be funded for that whole 6-week period. It's going to depend on how long it takes the relevant health and social care bodies to complete the necessary assessments and make eligibility decisions. And once that eligibility decision has been reached, that will then determine whether or not the patient will continue to be funded by the NHS, or whether they will become the responsibility of the local authority and any provision is subject to means testing, or if they don't satisfy the means testing rules and they're not eligible for CHC, then the patient will be a self-funder, subject of course to whether they qualify for something like the NHS funded nursing contribution. So with regard to the hospital discharge process, what's changed? Well, as I've mentioned at the start, the idea behind the Coronavirus Act 2020 was to expedite the safe discharge of patients from acute hospitals to free up acute beds as quickly as possible. And that idea is obviously still quite crucial as we continue through the coronavirus pandemic, because there is still going to be a need to make sure that we keep acute hospital wards as free as possible in order to keep enabling the NHS to respond to the changing demands and fluctuations in demand that COVID poses. So under this process, at the point at which a patient is deemed safe and ready for discharge, the patient should be discharged as soon as possible, but in any event, that same day. And the hospital discharge service requirements, which is the guidance that supports this, and will support the implementation of the simplified discharge process, has been updated with effect from the 1st of September. So from the 1st of September, for patients being discharged from hospital, an assessment of the patient's longer-term care needs, including any Social Care Act 2014 needs assessments and NHS healthcare or NHS funded nursing care assessments, should be undertaken during the individual's so-called period of funded recovery services. That period of funded recovery services can be up to a maximum of 6 weeks, and there are 4 discharge pathways. The expectation is an assessment for ongoing health and care needs will take place within 6 weeks of discharge and a decision made as to how care will be funded. After the end of the 6th week of that funded recovery period, CCGs will not be able to draw down from the discharge support funding, and essentially this is just a separate pot that the government has allocated to the NHS to fund these changes, to fund any care packages beyond this date. Any further costs after that 6-week period will not be able to be recovered by the relevant bodies from the discharge support funding pot, and they'll have to be met from CCG's existing budgets. If a decision is not reached within the 6-week time frame, the parties paying for the care should continue to do so until the relevant ongoing care assessments are complete, albeit the hospital discharge guidance states that this should only occur on a very rare occasion. So just to reassure anyone who's listening to this webinar, if you get to the point where you are supporting someone who has been discharged from hospital and the 6-week funded period runs out and the relevant assessments have not been completed, they cannot be left in limbo essentially if the relevant ongoing care assessments have not been completed by the responsible local authority and NHS bodies. All that happens is CCGs and local authorities from the 7th week after that 6-week period has expired will need to either agree local arrangements for the funding of care once that 7-week period has passed, which obviously affords discretion to individual bodies and will require patients, families and representatives to make themselves familiar with the local arrangements in their area, or if there is no local arrangement in place, the relevant CCGs and local authorities will have to adopt what's being termed as the default approach in the updated guidance that's been provided. And according to the updated guidance, that default approach, where a local arrangement about how funding care is going to work if a patient hasn't been assessed by the expiry of the 6-week period, the costs are allocated according to, or should be allocated according to what point in the assessment process has been reached by the end of that 6-week period of funded care. So where the NHS continuing healthcare or NHS funded nursing care assessments are delayed, it will be the CCG who remains responsible for paying for that patient's funded care until the NHS continuing healthcare or funded nursing care assessments have been completed. After this, where the individual is assessed as not eligible for NHS continuing healthcare or NHS funded nursing care, then responsibility will sit with the local authority in line with existing procedures until a Care Act 2014 needs assessment and eligibility determination has been made, and once that decision has been reached, normal funding rules apply, i.e. if an individual does not satisfy the eligibility criteria for NHS funded care, they've been assessed under the Care Act 2014, and perhaps they've got eligible care needs, but they do not satisfy the means testing rules, then at that point they're going to have to consider whether or not they are effectively a self-funder and will be required to fund any further care costs going forward. So one question I think a lot of us who are listening to this webinar are probably going to have in our minds is what is going to happen to an individual's discharge, I'll rephrase that. What happens to individuals' discharges from or who would have been admitted to hospital between the period of the 19th of March and the 31st of August, whereby those discharges and the care packages put in place were funded under the temporary COVID-19 NHS funding. So this is obviously the pot of money that was put aside by the government and given to the NHS to fund packages during this period when CCGs were afforded the flexibility not to complete the NHS continuing healthcare and NHS funded nursing care assessments. Well, the answer is, according to the guidance, that people funded through the COVID-19 discharge to assess funding arrangements that were in place between the 19th of March and the 31st of August should continue to be funded under those arrangements. Health and social care assessments should be completed for these individuals as soon as is practical to ensure that they can then transition to normal funding arrangements. So there should be no gap in care. It cannot be the case that the responsible local authority or CCG writes to you on the 1st of September and says, in line with this updated guidance, your current package will no longer be funded, and pull the plug and effectively leave you without any funding for your package of care. They would not be able to withdraw that COVID funding and withdraw from those existing arrangements until the usual health and social care assessments and eligibility determinations have been made. So until such time as an NHS continuing healthcare eligibility assessment has been completed and a decision reached, or a Care Act needs assessment and some form of financial assessment has been completed, you should continue to be funded under that temporary funding so that there isn't a gap and you're not left without care funding until those assessments have been completed. So hopefully that will provide some reassurance. If an individual who has been funded under the temporary COVID-19 funding during this period, the 19th of March to the 31st of August, because these changes take effect from the 1st of September, is then assessed as eligible for NHS continuing healthcare funding, so a checklist assessment has been completed, that's determined that a full eligibility assessment is required, and then an MDT has been convened, a decision support tool has been completed, and that has led to a determination that the person demonstrates a primary healthcare need and is therefore eligible for a package of non-means tested NHS continuing healthcare. At that point, responsibility for meeting that individual patient's care costs should transfer to the responsible CCG's core NHS continuing healthcare budget. If an individual funded under the temporary COVID-19 funding is not eligible for NHS continuing healthcare after that eligibility assessment has taken place, then payment of their care costs will transfer to the responsible local authority following the end date of the NHS continuing healthcare assessment process. Local authorities will then need to determine if the individual will qualify for means tested support under the Care Act, or in the event that they do not satisfy the means testing rules upon financial assessment, if they are going to be self-funders. Where individuals are assessed and found eligible for NHS continuing healthcare, or the local authority funded any part of their care while they were awaiting the NHS continuing healthcare assessment to take place, the responsible clinical commissioning group should arrange for refunds to take place if the funding arrangement that was in place is said to be consistent with the national framework. And according to the updated guidance, CCG should make appropriate reimbursements in accordance with the principles listed on the slide there. So that's where an NHS continuing healthcare checklist assessment has been used, and the costs of services from day 29 of the CCG receiving the NHS checklist should be reimbursed in accordance with Annex E, paragraph 9 of the National Framework. Or where an NHS continuing healthcare checklist assessment has been used and the individual's needs have changed by the time the full assessment is completed, because perhaps a period of time has passed, and obviously it's quite common for people's needs to change, particularly if there's a longer period of time involved. Then the responsible CCG will need to reimburse back to the point in time from which the individual was determined to have a primary health need. Or if during the period above only, no NHS continuing healthcare checklist assessment was used, then the CCG will need to reimburse back to the point in time from which the individual was determined to have a primary health need. Now, one issue that I think we're going to face, and I'll come on to this in a bit later, is actually people who might well fall through the gap, because I think there's going to be some confusion around when it is necessary to complete an NHS continuing healthcare checklist assessment and screen somebody to determine if they require a full eligibility assessment. But there is actually guidance in paragraph 91 of the National Framework, which provides the circumstances in which it is not necessary to complete an NHS continuing healthcare checklist assessment, i.e. the screening tool to determine if a full eligibility assessment is required. And those circumstances are as follows. It is clear to practitioners working in the health and care system that there is no need for NHS continuing healthcare at that point in time. Where appropriate or relevant, this decision and the reasons for it should be recorded. Or the individual has short-term healthcare needs or is recovering from a temporary condition and has not yet reached their optimum potential. In those scenarios, quite often a patient may be provided with re-ablement care, for example, and then at the point at which they've completed that package of re-ablement or rehabilitative care, they've reached their optimum, then it would be appropriate to begin screening them for continuing healthcare. And the reason is because if they are screened before they've reached their optimum, it may well skew the assessment of the individual's needs, and it may be very difficult to actually ascertain an accurate understanding of that patient's needs in the assessment process. Or it has been agreed by the CCG that the individual should be referred directly for a full assessment of eligibility for NHS continuing healthcare. Well, what does that mean? It is actually possible under the National Framework for a CCG to bypass the NHS continuing healthcare checklist assessment stage and go straight to full eligibility assessment, so there's an element of discretion there. Or the individual has a rapidly deteriorating condition and may be entering a terminal phase. In that situation, the individual should be bypassing the usual NHS continuing healthcare processes and should be fast-tracked using the fast-track pathway tool instead of a checklist assessment. An individual is receiving services under Section 117 of the Mental Health Act that is meeting all of their assessed needs. And for anyone who's not aware, where somebody has been detained under Section 3 of the Mental Health Act 1983 for treatment, at the point at which they are then ready for discharge, they are automatically entitled under Section 117 of the Mental Health Act 1983 to be provided with aftercare services to ensure that their needs upon hospital discharge are met, and also ultimately to make sure that the right care and support is put in place to prevent a relapse and possible need for a readmission to hospital. Or it has been previously decided that the individual is not eligible for NHS continuing healthcare, and it is clear that there have been no change in needs. And I should point out that if any bodies, health and social care bodies involved, say to a patient or their representatives and the families supporting a patient that they do not believe it is necessary to complete an NHS continuing healthcare checklist assessment, I would be questioning why and ask them to actually specify exactly the basis upon which they've reached that decision with the evidence recorded as to why and the reasons. Go back to this list of reasons in paragraph 91 of the National Framework, and don't be afraid to challenge that determination if it's appropriate to do so. One of my concerns about these changes is that there is a risk that people who should be screened for NHS continuing healthcare through the NHS checklist assessment process may well slip through the net, and I think the reason that might become a bit of a problem is because people may be wrongly advised that a checklist assessment is not required, i.e. They may be told that one isn't required and it doesn't fall within the circumstances in which the paragraph 91 of the National Framework provides it isn't necessary. Or alternatively, the other problem is going to be that because of the introduction or the reliance on the trusted assessors model and the fact that a number of health and social care professionals may not be familiar with the checklist and NHS mental health care eligibility assessment processes, that actually health and social care professionals may not have the relevant training to understand when a checklist assessment should and should not be completed because they're unfamiliar with the process. And so again, I think it's going to be quite important that people are prepared to speak up for themselves in these situations, because it is quite probable that the people completing the assessments may well have only recently undergone their training on the assessment processes and when it is appropriate to screen, when it is not, and how to conduct the assessments themselves. So the discharge to assess pathways according to the revised guidance are listed on the slide there. And I'm not going to read them out word for word. It's just to give you an idea of what the hospital discharge teams will be bearing in mind when it is considered that a patient is ready for discharge. And there is a diagram here that's actually extracted from the guidance, which helps to sort of summarize how those different discharge pathways work in practice. So there are 3 stages according to the revised guidance. Stage 1 is to review each individual daily and identify those patients who are ready for discharge and ready to leave that day. Please note that the guidance is quite clear that for patients being discharged to a care home, supported living environment, or to temporary accommodation, a COVID-19 test must be carried out prior to admission. And obviously there were a number of problems earlier in the pandemic of patients being discharged, or reportedly rather being discharged to care homes and other facilities without being tested for COVID-19. And at that point it was very difficult to then for care providers and placement providers to actually have an accurate understanding of whether individuals were entering care facilities with COVID or not. So obviously the intention behind this is to try and manage that risk better. Stage 2 concerns the details of how to discharge people, and the guidance is quite clear that on decision of discharge, i.e. it is decided that the patient should be discharged, the patient, the family, and or any carers involved must be informed of the discharge decision, and they should receive a discharge information leaflet, and the guidance actually has a standard leaflet that should be used. Health and social care professionals are expected to work together to ensure that patients are discharged in a safe and timely manner, and so there should be no reason to fear that a discharge is going to be unsafe. If a discharge decision is made and you do have concerns that it isn't going to be a safe discharge, then again, do not be afraid of raising those concerns, because ultimately the last thing that anybody wants is a failed discharge, meaning that the person may end up being admitted back to hospital. For people who require reablement, rehabilitation, and or any other package of care, followed by further assessment after recovery, for a period of up to 6 weeks, details of their immediate care needs should be passed to what's being called a single point of access, and a case manager should be appointed. All patients should be transferred to an allocated discharge area from the ward as soon as possible so that they can leave the hospital that same day. Patients and their families should be fully informed by the case manager of all the next steps involved, and so-called settle-in support should be provided if it's needed. And stage 3 relates to assessment and care planning at home. So post-discharge, case managers and the single point of access team should work with community partners in health and social care to ensure the immediate care needs of the patient are being met. If longer term support is going to be needed, then the use of personal budgets should be discussed with the individual and their family as an option to consider. And for anyone who doesn't know, personal budgets are essentially a way of personalising care and trying to give control and freedom and flexibility to the patient or their representative to manage their care perhaps at home, for example, if that's appropriate, rather than having to always consider going into a residential or nursing care facility. Obviously, whether personal budgets and direct payments are appropriate, it really depends on the needs of the patient and the type of care that they're going to require. For all patients discharged on the discharge pathways 1 to 3, services providing additional care to that patient should be in place pre-admission. and those should be provided at no cost to the individual patient for a period not exceeding 6 weeks. When I say should be in place pre-admission, I mean that if a care situation arises and a individual is going to be discharged, then the care and support they actually need should be in place before they're admitted to that setting, and that could be funded for a period of up to 6 weeks. And the case manager should be liaising with health and social care professionals to ensure timely assessments are completed if any longer term care provision is to take place. And also it's worth pointing out, as it does also do in the guidance, that the duties under the Mental Capacity Act 2005 still apply, and so for any patient who lacks capacity, best interest decision-making processes should be followed in any of these assessment processes and decisions about where a patient is to be discharged to or what care may be appropriate to ensure their longer-term care needs are met. So that was a quick overview of the changes. Some of you may well not be familiar with what NHS continuing healthcare is and what the assessment process involves, particularly given that it has been on hold in most cases until now. So I thought it would be useful to have a quick gallop through the process to make sure that you're familiar with it and to help support any of those patients or loved ones that you're helping as they go through these assessment processes over the weeks to come. So NHS Continuing Healthcare, in very simple, broad terms, is a non-means tested, complete package of ongoing care that is arranged and funded solely by the NHS, where an adult aged 18 and over has been assessed and found to have what's called a primary health need as a result of an injury, illness, or disability. Eligibility for NHS Continuing Healthcare means the NHS is responsible for care provision and meeting all of the associated costs. It can be provided in any setting, i.e. at home or in a care facility, and may cover the cost of accommodation, such as residency in a care home, if this is necessary to meet the assessed care needs of the patient. What does the assessment process involve? Well, it consists of 2 stages, and I've mentioned these already in the context of the changes I've just been talking about. The first stage is the checklist assessment. Now, the checklist assessment is a screening tool, and the idea behind it is it should be used to determine whether a full eligibility assessment is required. The threshold to pass the checklist assessment has actually been set intentionally low, and the assessment itself is split into 11 care domains broken down into 3 levels, A, B, or C. A full eligibility assessment is required if the individual scores 2 or more A's, 5 or more B's, 1A and 4 B's, or 1A marked with an asterisk. And the tool itself can be completed by a variety of health and social care professionals, and indeed the updated discharge service requirements guidance refers to the fact that trusted assessors may also be used in order to complete the checklist assessments. The second stage of the assessment process requires a multidisciplinary team meeting to be convened, an MDT, and that MDT will have to complete what's known as the decision support, or commonly referred to as the DST. For anyone who passes the checklist assessment and they've got a positive checklist, so that means they've scored 2 or more A's, 5 or more B's, 1A and 4 B's, or 1A marked with an asterisk. Then the second stage is to convene this MDT to complete the DST. So they must go from a checklist assessment to this second stage of the process. The MDT should be made up of both health and social care professionals who are knowledgeable about the individual patient. Family and representatives should be invited to attend and actively participate so that the MDT can collectively complete the DST. The DST is divided into 12 broad areas of need known as domains, and I've listed them there on the slide 1 to 12. So I won't read the whole list, but examples of the care needs that the assessment will consider include nutrition needs, a person's mobility needs, a person's cognitive needs, and so forth. The MDT must consider and apply the evidence, and that's evidence provided by the family, any care professionals involved, and within any relevant medical and care records, to the descriptors to determine whether each domain is of a priority, severe, high, moderate, low, or no level of need. When I say descriptors, for each of those 12 care domains on this slide, there are certain descriptions under each one which explain how you rank a person's need in that domain as either priority, severe, high, moderate, low, or no level of need. And it's worth pointing out that the priority level of need is not applicable in all of the domains. It's signposted or marked rather on the DST tool in which domains priority as a level of need which is available to the MDT. Once needs are established, certain characteristics known as the key indicators and their impact on the care required to meet need are used to determine whether the care required goes beyond the lawful remit of a local authority. A primary health need should be established when the totality of an adult's needs are considered to be within their nature intense, complex, or unpredictable to manage. And here is a helpful diagram that's actually been extracted from the National Frameworks Guidance, which shows you the different levels of need available in each of the 12 care domains listed on the previous slide. And then it also shows how the complexity, intensity, and unpredictability key indicators kind of fit around those levels of need when considering someone's needs in their totality. According to guidance, eligibility, i.e. someone should be found eligible for NHS continuing healthcare, would be expected in each of the following cases. A patient has a level of priority needs in any one of the 4 domains that carry this level, or a total of 2 or more incidences of severe needs across all the care domains. Where there is either a severe level of need combined with needs in a number of other domains, or a number of domains with high and or moderate needs, then careful consideration must be given to the 4 characteristics, namely nature, intensity, complexity, and unpredictability. So if after completing that DST at the MDT agrees that the patient has a priority level of need in any one of the 4 domains that carries, they should be found eligible. If the MDT identifies that the patient presents with 2 severe needs, then the patient should be recommended as eligible, but the MDT's recommendation has to be submitted to the CCG for ratification, and it is sometimes the case that the CCG may not agree with the MDT's assessment of the levels of need, and in that scenario there is a process that the CCG should follow under the National Frameworks Guidance for actually questioning any concerns a CCG has over the MDT's assessment, whereby the assessment should be sent back and then MDT should be reconvened to reconsider the individual's needs, rather than the CCG simply not ratifying MDT's recommendation and effectively making its own decision. And once the CCG has ratified a decision, the decision should be confirmed in writing, along with information about how to appeal any decision of non-eligibility. So what happens if a patient is identified to not be eligible for NHS continuing healthcare? In that scenario, the CCG may award either the NHS-funded nursing contribution, commonly referred to as the FNC, and that's a set weekly rate of £183.92, which will be paid directly to a provider to facilitate the provision of nursing care. So it's only relevant if the individual requires nursing care, and that's been identified on the needs assessment, and the rate is subject to change. Or the CCG may potentially award a jointly funded care package, which means the CCG and local authority will split the cost of care, but the social care part of the package will be subject to the normal means testing rules. And if neither of the above applicable, then responsibility for meeting the patient's needs will rest with the local authority under the Care Act, and obviously then any social care provision that's required to meet the person's needs is subject to the means testing rules, and if an individual does not satisfy those means testing rules, is not eligible for the funded nursing contribution, then there'll be a pure self-funder. Can eligibility decisions be challenged? The answer is yes. There's a 2-stage assessment process. The first stage is called the local resolution process, and the second stage is called the independent review panel process, and that's managed by NHS England. So the first stage, local resolution, requires you to appeal to the original decision-making body, i.e. the CCG that's made the decision, and ask them to reconsider their decision again. And there is a process set out in the national framework for how the local resolution process should be conducted by a CCG. And if you do not resolve your concerns at the local resolution stage, so you've appealed to the CCG, you've been through the relevant process, and the CCG at the end decides they want to uphold their original decision, then you are eligible at that stage to consider escalating it to NHS England and ask NHS England to consider convening an independent review panel to consider the CCG's decision. At that stage, the independent review panel will be made up of health and social care professionals not involved in the original decision-making process, and they will be appointed at random from a pool of candidates from other local authorities and CCGs across the country, and the panel will be chaired by an independent chair, usually with a medical advisor as well, and they will reconsider the case afresh. But the benefit, of course, at that stage is you're taking the decision out of the hands of the original decision-making body and placing it in the hands of an independent panel, and so you may well find that you get a different approach or response. All eligibility decisions must be challenged within 6 months of the date of the CCG's original decision-making letter, and it's most likely at the moment that any eligibility assessments, annual reviews or appeals are probably going to be conducted remotely using video technology due to the social distancing guidelines. I should also point out that if you find that as a result of an eligibility assessment, a CCG determines you are not eligible, you then don't satisfy the means testing rules for social care support, and nor are you awarded the funded nursing contribution, so you don't have that as another prong to the funding that's available to support your care costs, and you're a pure self-funder. If you then decide, and your representative decides on your behalf to take forward a challenge, and you subsequently, as at the local resolution stage or NHS England stage, find that the previous decision of non-eligibility is overturned, you do have a right to redress, and so you can recover from the responsible CCG the costs of care incurred during the period in which the later appeal decides you should have been identified to have had a primary health need, and so the NHS should have been funding your care, and you're also entitled to interest on any care fees that are recoverable at that stage. So whilst you would have to self-fund your care if you fall into that category, whilst you're waiting for your appeal, if the appeal subsequently overturns that original decision, you would be entitled at that stage to recover care costs incurred during the period in which the responsible NHS body, the CCG, should have been funding your care, but also you'll be entitled to your care costs being met going forward until such time as annual reviews are completed, and if necessary at those annual review stages, an NHS body indicates that they feel needs have changed requiring a reassessment. A few points that I just wanted to make that were raised in our earlier webinar in April earlier this year that are not actually addressed in the updated guidance currently is that the duty to have regard to the National Framework for NHS Continuing Healthcare was actually suspended as a result of the Coronavirus Act 2020 and the associated coronavirus regulations. There's no comment on that point in the updated guidance so far, and I would hope that most NHS bodies will continue to operate against the national framework as far as possible, but just be aware that there is a risk that we may see some variations in the way assessment processes and decision-making processes are undertaken between different CCGs as a result of the suspension. So what can you do to prepare? Well, I would say it's essential to work with any carers or care providers over the coming weeks and patients, families, attorneys, deputies to begin preparing for assessment processes, annual reviews or appeals that have previously been on hold. NHS Continuing Healthcare is an evidence-based process, and so it will be vital to ensure that they have detailed care records, care diaries, intervention charts and notes available to demonstrate that a patient presents with the primary health need criteria and therefore should be found eligible for a fully funded, non-means tested package of NHS Continuing Healthcare. And ultimately, thorough preparation is going to be critical to success. And if you don't succeed at the first stage, i.e. you've got through the checklist, you then have the MDT, you complete a DST, and the MDT comes back with a decision of non-eligibility, don't give up. Don't be afraid to follow the processes for challenging the decisions through the local resolution process, or if needed, escalating it to NHS England to request an independent review panel is convened. So in summary, the changes I've discussed in this webinar are effective on the 1st of September. The discharge to assess process has been simplified a bit further under the updated guidance, and the focus remains on ensuring patients are discharged in a timely fashion. Needs assessments, including NHS Continuing Healthcare eligibility assessments, annual reviews and appeals, should begin again. I've said there beware of annual reviews, and that's because increasingly I'm finding with families that I support at Leicester Aldridge that annual reviews are often being used as an opportunity to withdraw somebody's NHS Continuing Healthcare funding. And sometimes, in fact, the correct process for completing an annual review and then getting to the stage whereby it is determined that a patient's needs have changed, meaning they no longer need the NHS funding, isn't always followed correctly in accordance with the guidance in the national framework. So it is quite important to make sure you are prepared for any annual reviews, to make sure you protect yourself or your loved one from the risk that an annual review process could lead to a process being instigated with a view to withdrawing the NHS funding. And the updated guidance is silent with regard to the suspension on the duty to have regard to the national framework that I mentioned in the previous slide, but I would imagine that CCG will hopefully conduct processes in accordance with the spirit of the national framework as much as possible. There is a risk that patients who should be screened for NHS continuing healthcare assessments by way of the checklist assessment may miss out if checklist assessments are being completed by health and social care professionals who are unfamiliar with the process. And if that is the case, I would urge any patients or families and representatives helping a patient to speak up for themselves and challenge if a checklist assessment isn't completed when it should be. Don't be afraid to say so and make sure that you are screened in the right way. The period of funded recovery services may be provided to a patient for up to 6 weeks pending completion of health and social care needs assessments. If a decision regarding eligibility for NHS continuing healthcare is not reached within this 6-week timeframe, the parties paying for the care should continue to do so until the relevant ongoing care assessments are complete, so you should not be left in limbo, or your loved one should not be left in limbo. People funded through the COVID-19 temporary NHS discharge funding arrangements between the 19th of March and the 31st of August should continue to be funded under those arrangements until the health and social care assessments have been completed, albeit the guidance is suggesting that they should be completed as soon as practical to ensure they transition to the usual funding arrangements we're all familiar with. And public bodies should be acting under either a local arrangement or the default approach when it comes to what to do if assessments are not completed within that 6-week period. And ultimately, you need to be prepared for any assessment, annual review or appeal in order to maximise your chances of successfully securing the funding or maintaining the funding. So that brings me to the end of today's webinar. I appreciate we've covered quite a lot of content, but if after watching you have any questions, please feel free to email them to inquiries@braininjurygroup.co.uk and I'm happy to answer queries by email. Thank you for listening.